some audio in the background.
Yes, him only. Yeah, he's put it off.
Sure, thank you. So, good evening, ladies and gentlemen. Welcome to another exciting episode of Mumbai Hematology Group. Today is Thursday, 13th August 2026, and we have two live lecture, and we intend to close it by 8:30 to 9 today. Thank you for joining us in the large number. All this has been possible courtesy the tireless work of our program director, Professor Dr. M.B. Agarwal sir, who needs no introduction. 4 decades plus of hematology clinical practice shaping, 4 decades of academic education in that particular field, and 4 decades of contribution to professional bodies and coordinations and collaborations with best mind in the field of clinical hematology. So we are grateful to you and a warm welcome to you. You hold a lot of posts, a lot of privileges, but just to mention a few, Lifetime Achievement Award by Indian Society of Hematology and Blood Transfusion, 120 plus original article published in national and international repute, 25 plus orations, plus numerous national and international award. And sir, post-COVID, close to 600 webinar, academic webinar. What can be better than this? Worth all the global recognitions, I must say. And you have been advisor to Thalassemia International Federation, Thalassemia Society, Maldives. Thank you very much, sir. And may I request you to take it forward from here.
Can you see my slide?
Yes.
Okay. So thank you, Dr. Manoj, for those kind words. Good evening to everybody from India. This webinar is brought to you by Mumbai Hematology Group. Today's webinar is supported by INTAS and J&J, managed by Perfect Square. Your two guest speakers, Dr. Neha Kamble from Pune and Dr. Samir Al Hadidi from Texas. I'm grateful to Team INTAS and JJ for supporting our educational activity. Mr. Yash, Mr. Kalpesh and the Team Perfect Square, Executive Committee of Mumbai Hematology Group for giving this free hand to me. The guest speakers, Dr. Neha Kamble from Pune and Dr. Samir Al Hadidi from Texas. All our discussants were themselves eminent hematologists or medical oncologists or hematopathologist, and you participants for sparing your Thursday evening. Coming Thursday, that is 28th of August, we have another two sets of webinars. 6:30 p.m., we have Dr. Sarai Ahmed from Houston, Texas, MD Anderson, redefining the goal in Hodgkin lymphoma in the era of novel therapies. And following her is Dr. Rahul Banerjee from Fred Hutch, Seattle, speaking to us on cell modes, the next generation IMIDs. Coming back to today's, it's my pleasure to introduce my friend and colleague, Associate Professor Dr. Neha Kamble, MD, FIDH, India Rice Fellow, PhD Scholar. Assistant Professor, Dr. D.Y. Patil Medical College, Hospital and Research, Pune, India. President, Medicare Charitable Trust Foundation, India. Founding Director, Sciences Trust Foundation, India. She is a consultant hematopathologist with expertise in hematological malignancies. Her major areas of collaborative work being Europe. In India, she is working as an assistant professor, Department of Pathology, DY Medical College, Hospital and Research Center, Pune, as I said earlier. She did her fellowship in diagnostic hematology, followed by specialization in experimental hematology from Barcelona, Spain. She's also trained in flow cytometry and CAR-T cell unit from Spain and has an integral role in setting up the meniscal tissue biobank. She's been awarded with the coveted India Rise Fellowship 26-27 in the cohort of 41 best women STEM researchers across the country. She's also pursuing her PhD in myeloid malignancies with focus in optical genome mapping in India, along with a master's degree in molecular oncology from Europe. She is the founding director of the Sciences Global Healthcare Private Limited India, through which she helps place hematologists in Asia Pacific and neighboring countries for fellowship opportunities in Europe in various subspecialties of hematology through academic collaborations with university hospitals. She's the president for Medicare Charitable Trust Foundation, which primarily works on medical, academic, research, and social fronts and is actively involved in philanthropic activities. Today, she's going to lecture us on the marrow under siege, deciphering cytopenias in blood disorders. With that, I hand over the platform to her.
Good evening, Dr. M.B. Agarwal, sir. Good evening, dear all. I'm grateful to sir for the wonderful introduction, and a very big thank you for the team for having me with you today. So kindly allow me to share my screen. Yeah. Kindly let me know if the presentation is visible, sir.
Visible.
Okay, great. So just for the convenience, I would switch off my video feed so that we do not have any disturbances with the net connectivity. Okay, lovely. Okay, so the topic for today that we have is marrow under siege, deciphering cytopenias and blood disorders. As I said, a very big thank you to Dr. M.B. Agarwal, sir, and Mumbai Hematology Group for the wonderful invitation. What this session should change. So it's a very basic topic where we are looking at cytopenias, wherein we are encountering cytopenias day in and day out into our routine practice. So what this session should actually change is where we recognize cytopenia just as a phenotype, but not as a diagnosis. We try to localize the exact defect which is actually leading to the cytopenia. So maybe the defect is with your production, your ineffective hematopoiesis, destruction or consumption, sequestration, or dilution effects. And using effectively CBCQs, reticulocyte count, smear, and marrow together rather than sequentially in silos. Since in India we have majorly resource restricted settings, I believe all of these basic workup would really help you in reaching out to maybe a cause which is causing the cytopenia, and a separate reactive or nutritional cytopenias from marrow failures, infiltration, and clonal myeloid diseases. And to know when cytopenia demands urgent action and when it demands molecular and cytogenetic classification. So it's a morphology to mechanism based diagnostic approach rather than a diagnosis itself. So just for the ease of understanding, I've included 3 cases which actually focus on different causes. So the first case is of a 68-year-old, fatigue, bruising. There's no fever, no splenomegaly, and no history of recent chemotherapy. But the patient has cytopenias, where hemoglobin is 7.8 with an MCV of 103, ANC of 0.7 into 10 to the power 9 per liter, platelets of 42,000. So the differential diagnosis with this kind of picture generally that would come to your mind and everybody's mind would be, is it megaloblastic with the MCV of 103? Is it MDS? Could it be aplastic? Could it be acute leukemia? Or it is just a drug effect that is causing cytopenias? So the key question here is not what is causing the cytopenia. It is where in hematopoiesis is the failure actually happening, which is giving you cytopenias as a presentation. So for cytopenias, we need to define the phenotype before actually naming or classifying the disease. So either a single lineage where you have anemias, you have neutropenias, you have thrombocytopenia, or is it bicytopenia where any 2 lineages are reduced? The mechanism may still be systemic or it could be marrow based. or it is pancytopenia, where all the three major lineages are reduced. And primarily, we need to think about some marrow failure, some marrow infiltration, or ineffective hematopoiesis or sequestration, or an entirely different etiology as a systemic illness. So the combination usually is more informative rather than a single entity alone. So it has to be a combined evaluation of severity, your lineage patterns, as in you're looking at a single lineage cytopenia, bicytopenias, or a pancytopenia, and also the marrow response. So these are much more informative than the label of cytopenia alone. So mechanism first reasoning. So 5 mechanisms commonly explain most of the cytopenias. Firstly, biologic, that you do not have enough production. So there's reduced production where there is a stem or a progenitor cell failure or there's a suppression. Second, that it is ineffective hematopoiesis. That means the cells are being produced, but they die in the marrow itself. Third is when we come out of the marrow, where there is peripheral destruction, which means the marrow is making it. However, because of immune or non-immune causes, you're losing it out in the periphery. Or you're not losing it out in the periphery, or there is a consumption or a loss etiology. For example, like DIC or bleeding or microangiopathy. And finally, it could be a sequestration cause, like in hypersplenism or a redistribution. Whenever, and by the time we are looking at the cause of cytopenias, we have to always remember that there has to be a clinical triage constantly happening, because this cytopenia could be an emergency as well. So as much as a hematopathologist looking out or trying to find out a cause of cytopenia is important, it is equally important to actually clinically triage at our end as well. So when we are looking at neutropenias, in severe cases of fever or severe cases of sepsis, this kind could be a presentation where there is profound ANC reduction, or there has been a recent cytotoxic therapy, or there is a mucosal barrier injury. We are looking at severe thrombocytopenia where there is active bleeding, there is neurological or renal features. You are seeing schistocytes or suspected TMA, which is a pretty much an emergency. Or you're looking at a DIC-like phenotype commonly seen with APMLs. Or you're looking with anemia, where there is an hemodynamic compromise, acute blood losses, hemolytic crisis, or a cardiopulmonary ischemia. So stabilization and mechanism finding, this should often proceed in parallel, saving as much as time as possible. So when we are looking at the CBC intelligence, so as a pathologist or a hematopathologist, so we need to read the CBC as a pattern and not just 3 numbers, which are showing you HbTLC and platelet. So for the RBC axis, we need to be diligently looking at your MCV, your MCH, RDWs, your reticulocyte count, if you're seeing any nucleated RBCs in the periphery, any dimorphic populations, where there's macrocytosis without reticulocytosis, which indirectly, indicates it is an ineffective production. Or you're looking at a WBC axis, where absolute counts matter, but not the percentages majorly. Your neutrophil maturity, monocytosis or lymphocytosis, left shift versus blast. There is persistent explained neutropenia, where you need to look out for a marrow for a context. Or looking at the platelet axis, where the cytopenia or thrombocytopenia, is it really true or is it pseudothrombocytopenia? Are you seeing any clumps where when you get corrected, you have a normal platelet counts? Are you seeing giant platelets? What kind of MPV number are we looking at? There's isolated thrombocytopenia or multilineage. Is there a consumption clue to it? Or there are large bizarre platelets that may signal a marrow infiltration. So these are the simple pointers that actually help you decide if there is a bone marrow examination warranted. So how do we differentiate between a production versus a loss effect, which is leading to cytopenias? So simple test for it, a reticulocyte count is the fastest localization test, right? So if you're looking at a low or inappropriate reticulocyte count, probably the marrow is in an under response. So either it could be an aplastic anemia, a PRCA, an MDS or ineffective erythropoiesis, nutritional deficiencies or maloinfiltration, which is leading to low production in the first place, where a correction of anemia can be done and where a reticulocyte response can be seen against the degree of anemia. Or against this, versus this, you have a high or appropriate reticulocyte count, which indicates that the marrow is producing, but the losses are probably happening in the periphery, which could be due to hemolysis, bleeding, response to replacement therapy, or recovery after suppression. So typically a normocytic normochromic anemia with reticulocytopenia plus a leukopenia or thrombocytopenia should raise a suspicion for intrinsic marrow disease. So basically we are looking at a pancytopenic picture with reticulocytopenia. So it warrants a bone marrow examination. Sorry. So morphology on a peripheral smear is also pretty much indicative after you have seen the RBC as a pattern. So peripheral smear shows major patterns that usually redirect the further workup. If you're seeing macrovalocytes or hypersegmentation, you're probably looking at a megaloblastic process. Typically, that we were seeing in our case 1. If you're seeing schistocytes, there could be a microangiopathic consumption. You're looking at teardrops, NRBCs, and left shift. So probably it could be a fibrotic marrow or myelopathic marrow. You're looking at blast or rods, which is an upfront evidence of acute leukemia or an advanced myeloid neoplasm. You're looking at giant platelets, where typically you see peripheral destruction or there is a marrow stress due to marrow infiltration. But context usually matters here as to what is actually causing it. Or you're seeing dysplastic changes like dysgranulopoiesis or hypogranulated cells, where you can consider a differential of MDS, but after excluding your common causes. So blood smear morphology is central to identifying marrow infiltration, megaloblastic change, and clonal myeloid disease. So the workflow, a practical diagnostic algorithm for unexplained cytopenias. So where we have ruled out all of the relevant causes which are commonly found, but still we have unexplained cytopenias. First would be to confirm. You repeat the CBC. Chances are probably a lot of times the blood sample is collected from the IV line, or probably the patient must have had a IV drip recently and the sample has been collected to the same site. So you repeat a CBC and make sure it is a true cytopenic picture that you're looking at. Exclude the possibility of clots, dilution effect as we discussed, or platelet clumping. You characterize how many lineages are reduced. You look at the MCV, your reticulocytes, smear examination, the patterns that we had discussed in the last slide. And you exclude the reversible causes like drugs, infection, B12, folate, or iron, the nutritional causes, or an external effect like a renal disorder or a liver disorder and a background inflammation. Then we localize if it is a peripheral loss or a sequestration loss versus a central marrow failure or ineffective production. Further, we can investigate the marrow, look at the aspirate, the biopsy, the iron status of the marrow, your flow wherever is warranted, your cytogenetics and molecular wherever is warranted. And finally, when we have all of these findings in hand, it is majorly an integrative diagnosis where you're looking at morphology, phenotype, genetics, clinical context, and also ruling out possibilities for any history of drugs, any kind of infections. So it is pretty much an integrated approach whenever we want to establish a cause for cytopenia. So now going back to the case 1 differentials that we have had, where the HB was 7.8, MCV 103, ANC was 0.7, platelets 42,000. So here the common reversible or reactive causes would be vitamin B12 folate deficiencies, copper or zinc excess, alcohol or liver disease, drug or toxin effect, viral infection, systemic inflammation, all of these causes. Or a context dependent mimics, for example, renal or endocrine contributors, autoimmune disease as well, hypersplenism, hemolysis, blood loss, recent chemo or radiotherapy. So all of these differentials come into picture when we are looking at this kind of picture. So it is typically a very at an elderly age with MCV of this much with no organomegaly. So it's very tempting to actually label this as MDS, but actively we need to exclude the mimics. Actively we need to exclude the nutritional causes, the systemic causes before labeling it as one. So clonality is pretty much a powerful evidence, but morphology and clinical exclusion still matters. Clonality, we are going to cover it in the next slides. So first pitfall is megaloblastic cytopenias, the classical pseudo MDS. So a lot of times that even we see in routine practice, a lot of our residents are very keen on labeling even a simple megaloblastic cytopenia as an MDS. So I believe a little thinking is always needed before upfront labeling, because the workup for MDS is not that cheaper. You need a lot of NGS, a lot of cytogenetic, a lot of flow cytometry workup for that. So always make sure we are not looking at a megaloblastic cytopenia only, rather than directly jumping to a malignant cause. So peripheral blood, macrovalocyte, anisocytosis, anisopoikilocytosis, you see a lot of hypersegmented neutrophils. So leukopenia, thrombocytopenia can be seen in severe diseases. Also, a lot of times hemolytic picture starts coming out in the periphery in severe megaloblastic cases. So bone marrow is going to show you hypercellularity, nuclear cytoplasmic asynchrony, ineffective hematopoiesis, and it may look strikingly dysplastic. So the first would be to resolve with B12 or folate assessment. A biochemical context is always helpful. Serum LDH, your serum B12, folate values, medication or diet history, if it's a pure vegetarian or non-vegetarian diet, and response to replacement therapy wherever appropriate. So decision point is, when does a cytopenia require bone marrow examination, or a lot of the times it can be resolved with resolving your systemic causes. So strong indicators would always be an unexplained bicytopenia or pancytopenia. So anemia usually first would be always to look for any nutritional causes. But if you're looking at a bicytopenia or pancytopenia, it always warrants to look at the marrow if you are missing something. A low reticulocyte response suggests an intrinsic marrow disease. Also presence of blast or leukoerythroblastosis, teardrops or dysplasia on smear warrants a bone marrow examination. Or you're looking at persistent cytopenias after reversible causes are excluded. Also suspected leukemias, MDS, aplastia, fibrosis or infiltration also warrant a bone marrow examination. And always look for answers in the marrow. So even simple little things that you're looking at marrow can help you reach a finding a cause or a diagnosis. So typically look for what kind of cellularity are we looking at? Is it appropriate for that age? Which lineage is reduced or abnormal? Is dysplasia significant and reproducible, and are blasts increased or abnormally localized? Or we are looking at entirely different etiology where there is fibrosis, you have infiltrate, you have necrosis or granulomas. So the bone marrow, whenever looking at a bone marrow, so cellularity immediately narrows down the differentials. So it could be an hypocellular for age marrow or a normocellular or entirely hypercellular for age. So hypocellular for age typically looks like you're looking at a aplastic anemia or a hypoplastic MDS. It could be a drug-associated hypocellularity, toxin-associated, or a radiation injury as well, infection associated to, or inherited marrow failure or rare hypoplastic leukemias. If you're looking at an ormocellular cellularity, it could be an early clonal disease or a peripheral destruction or sequestration. There could be mixed mechanism where multiple mechanisms are at play which are leading to cytopenias. It could be sampling issues. So sampling issues is one of the major pitfall that needs to be taken care of when we are trying to find out a cause in the marrow for a cytopenia in periphery. Or it could be an evolving marrow failure wherein it is a transitioning phase and you need to actually probably follow through with the patient to actually have a diagnosis with you. So it could be an evolving process, it could be a transitioning process. An entirely hypercellular marrow, typically seen with MDS or ineffective hematopoiesis. Megaloblastic anemias also give you, acute leukemias are going to surely give you myelofibrosis or MPNs, or marrow infiltration by hematopoietic or non-hematopoietic disorders. So cellularity is a localization clue if the problem is with your marrow or it's in the periphery, but again, it is not a diagnosis. So whenever we're looking at a hypocellular marrow, the two most commonest differentials with this kind of case scenario that we had seen could be aplastic anemia versus a hypoplastic MDS. So with aplastic anemia, the cellularity is going to be surely decreased. Hypoplastic, usually about in 15% cases, MDS is a hypoplastic. It is also decreased in the secondary cases. CD34 cells count would be markedly reduced in aplastic anemia. However, they could be normal or increased relative to aplastic anemia in hypoplastic MDS. Dyserythropoiesis, it may occur, but it is very common with MDS. Ring sideroblasts, usually not seen. Myeloid dysplasia or megakaryocytic dysplasia, usually not seen with aplastic anemias. However, they're very commonly seen. Whatever less cells that we have, they typically present with dysplasia. PNH clone is a very good test to actually differentiate between the two, where it's commonly seen in aplastic and it is rare in hypoplastic or MDS. And abnormal karyotype, it's quite rare in aplastic, which is very common with hypoplastic MDS. So when we are looking at marrow failure with this kind of picture, again, since the ANC is 0.7 into 10 to the power 9, it pretty much does not fit into the diagnosis of aplastic anemia. So commonly it is differentiated into a severe aplastic anemia and a very severe aplastic anemia, as we all know. So the gist of this is the count depth, especially the neutropenia, it drives the immediate infectious risk. So whenever we are looking at these kind of cases, ANC carries pretty much the similar value as much as your anemias. Second, the other differential that comes into picture with this kind of morphology or this kind of cytopenic CBC picture is MDS. But dysplasia needs to be quantified. You need to contextualize it and you have to distress it in isolation. So erythroid, you're going to see nuclear budding, irregularity, multinuclearity, megaloblastoid changes, ring sideroblasts, granulocytic dysplasia like hypogranulation, pseudopelgar Hewitt forms, abnormal nuclear segmentation or maturation disturbances. Megakaryocyte, micromegakaryocytes are seen, hypolobated nuclei, separated nuclear lobes, and abnormal clustering. But more than 10% dysplasia in a lineage is diagnostically significant. So MDS has to be a very thought-over diagnosis if you're looking based on just on the morphology. Integrated diagnostic comes into the picture. So cytogenetics and molecular data, they are educatives, but they are not substitutes. Cytogenetics is quite informative in resource poor settings. It gives you a diagnostic support, but yes, the major diagnosis quite most of the times lies on your morphology itself. So it gives you a prognostic stratification. A lot of prognostication models are in place. It helps distinguish hypoplastic MDS from aplastic anemia. And you have complex and chromosome semi abnormalities, which carry major weight and commonly seen. Molecular testing, it adds an evidence of clonality and prognosis again. It is useful in unexplained cytopenias, but the mutation patterns in the WAF matters. Clonal hematopoiesis can exist without MDS, and you can interpret with morphology and clinical context. So cytogenetics is crucial or required for MDS classification. However, mutational analysis is an important additional prognostication tool. So flow cytometry is also one of the useful tool when we are looking to look for a cause of cytopenias. Very commonly for acute leukemias, it helps you to detect or quantify abnormal blast, assign lineage assignment, and identify aberrant maturation. For MDS, it helps you to find out an abnormal progenitor compartment, granulation maturation abnormalities, cross lineage aberrancies, and it also useful when your morphology is subtle. So a lot of times the morphology is your marrow is quite hypercellular, and it is very difficult to actually set that cutoff of more than 10%. So probably flow cytometry could come in the picture and help you to see if you are having any maturation pattern aberrancies on flow cytometry. Other clonal diseases also can be picked up by flow cytometry, like PNH clone assessment to establish aplastic anemia, your LGL or your lymphoid processes to establish lymphomas, hairy cell leukemias, and plasma cell disorders. So, our integrated flow cytometric assessment in newly diagnosed cytopenias and MDS related features, flow could be really helpful. For cases of fibrosis, a leukoerythroblastic picture is pretty much telling you that the marrow is very crowded. So you see a peripheral blood constellation picture of nucleated red blood cells, teardrop poikilocytes, immature myeloid forms, large bizarre platelets, and anemia with or without thrombocytopenia. And you need to think beyond MDS, where probably we're looking at maybe a primary or a secondary myelofibrosis or an entirely different metastatic carcinoma. So something which is non-hematopoietic, lymphoma or leukemias, granulomatous diseases, a very simple thing that could be missed if you're not looking at the right places, storage disorders or severe marrow stress. So these mere abnormalities are highly specific, and they highlight as clues to marrow infiltration and an indication for a bone marrow examination. And also when we are looking at cytopenia, so not always the cytopenia is going to be caused by one compartment defect. It could happen due to multiple mechanisms all at the same time. A wonderful example for this would be hairy cell leukemia, where you have a marrow infiltration, so there is loss of effective hematopoietic space. So you're not having enough hematopoietic cells to come out in the periphery. Also, there is a cytokine-driven myelosuppression and fibrosis, where there is a TGF-beta associated stromal effect. And again, there is splenic sequestration and redistribution in peripheral pooling happening. So pancytopenia does not imply a single pathophysiological process. And a wonderful example for this is hairy cell leukemia, where infiltration, myelosuppression / fibrosis, and splenic sequestration, multiple mechanisms lead to pancytopenia in the periphery. Then we look at the platelets. So for the platelet pathway, thrombocytopenia, first and foremost, prove it is real. So you're not looking at a false negative value or a false low value. First, prove it real. If look at the smear, you have to exclude EDTA-related clumping, pseudothrombocytopenias, or probably clotted samples. You have to see if it is isolated or it is associated with other cytopenias as well. So if you're looking at an ITP or a drug cause, it is more likely, and if other lines in smear are otherwise normal. Is it a consumption defect? So in cases of DIC, TMA, sepsis, you have to integrate your coagulation findings, your hemolysis, your organ injury into a clinical context. Or there is an absolutely reduced production. So but it is usually associated with a multilinear cytopenia or dysplasia. Look at the marrow evaluation. Or it is a congenital defect with your megakaryocytes. Or there's a sequestration effect where you're looking at splenomegaly and a broader clinical context. The neutrophil pathway. So here the neutropenia, not only the neutropenia matters, but the severity, duration, and the company as well. So if it is an acute isolated episode of neutropenia, you have to look if there is the cause is due to some drug, or it is a remote viral illness that had happened, or is it immune neutropenia or sepsis associated. If this has been happening for quite a long time, if you're looking at a chronic component of it, we need to look for if there is any autoimmune process, or if there is any LGL associated neutropenia. There is a nutritional neutropenia, or constitutional, or inherited, or medication related. And if it is also associated with other cytopenias, again, the other differentials of aplasia, MDS, AML, megaloblastic processes, infiltration, fibrosis, or hypersplenism, all of these come into picture. So the presence of a second cytopenia sharply raises the probability of a marrow-associated process, as opposed to when you're looking at an isolated cytopenia, which is pretty much a lot of times associated with systemic causes. Sequestration is also one of the confusing and a confounding factor, which very much helps you to reach at a diagnosis when we are looking at cytopenias. So hypersplenism is actually a cytopenia with a functioning marrow, but the sequestration and the loss of cells is actually happening in the spleen. So clues which support your sequestration are splenomegaly as yes, portal hypertension or liver diseases, relatively preserved marrow production. You have often moderate multilineage cytopenias, and the morphology may be very non-specific. However, typical clues which are against a simple hypersplenism, or probably we are looking at an MPN in the marrow, you would have progressive macrocytosis, you would have circulating blast, you have marked dysplasia, leukoerythroblastic picture, a very low reticulocyte response, or an unexplained constitutional symptom. So it's very important whenever we are thinking of a sequestration effect. So probably are we looking at at an entirely simple cause like hypersplenism, or it is very different. So again, now case 1 is revisited. What should happen next? We were looking at an HB of 7.8, MCV of 103, ANC of 0.7, and a platelet of 42,000. So it's very tempting for a 68-year-old no organomegaly to call it as MDS, but it would be insufficient without exclusions and a marrow and a genetic context. So nutritional exclusion is required. So nutritional screen first, B12, folate, copper, your reticulocyte count, smear, a medication, and an alcohol history also. This would very much be warranted when you're looking at this kind of picture, followed by a bone marrow examination if none of this is explaining it. So an aspiration, biopsy, iron, flow molecular cytogenetic, and then we reach at a diagnosis. So the best answer for this would be first a nutritional screen, followed by a marrow picture and a detailed further workup in case nothing is explainable. At the same time, managing a clinical risk in parallel is very much important. As opposed to the first case, now there's a second case, a different picture, where we are looking at a hypocellular marrow, pancytopenic picture. So your findings are HB of 8.4, ANC of 0.35, your platelets are quite reduced, 14,000. Your reticulocyte counts are very low, and your marrow cellularity is about 15%, which is low as opposed compared to the age. Morphology on the bone marrow, you do not have any increased blast. There's no convincing granulocytic dysplasia, or megakaryocytes are markedly reduced, and no ring sideroblast. So educators for this kind of picture would be a karyotype which was normal, a small PNH clone was detected, and CD34 cells were markedly reduced. So it's pretty much a clear diagnosis over here. So it's a most coherent diagnosis, aplastic anemia phenotype, and not a hypoplastic MDS, because we have a PNH clone and we have a CD34 count which is markedly reduced. So this is a typically hypocellular marrow pancytopenia, similar kind of picture, but however the ANC is quite low and a PNH clone. Now we have a case 3, similar kind of picture, where there is cytopenia and mutation, but it not always automatically give you a diagnosis of MDS. Here again, your HB is 10.1, ANC is 1.4, platelets are 1,05,000. This has been persistent since the last 8 months. When a marrow is done, you have a normocellular marrow, blasts are just 1%, 1 to 2%. Dysplasia is typically less than 10 in all the lineages, and there are no defining cytogenetic abnormalities. But on your molecular studies for NGS, you have a TET2 with a significant VAF and no other pathological variants. So here we are typically looking at a clonal cytopenia, where it is a key consideration, and then you follow the patient longitudinally. Why? Because you are seeing a typical dysplasia of less than 10 and cytopenias. So clonal cytopenias are a little difficult to actually pinpoint and difficult for hematopathologists to actually put on paper or probably have a longitudinal follow-up for these patients. And I would love to have inputs from all our esteemed dignitaries as to how do we follow through for a clonal cytopenia case as a physician. So whenever we're talking about clonal cytopenias, I think it warrants the mention of the sibling entities that come with it. So with clonal cytopenias, there's persistent unexplained cytopenia, but when does it become an MDS? So ICAS, CCAS, MDS, CHIP, IDUS, all of these are the brother-sister entities of MDS, where subtle differences actually make change the diagnosis. So ICAS is where you have cytopenias, but there is no diagnostic dysplasia and no clonality. So you just have cytopenias. With CCAS, you have cytopenias, but then you have a minimal or a non-diagnostic dysplasia. So the VAF doesn't fit into MDS, but you have dysplasia and you have a somatic clonality. For MDS, out and out, you have cytopenias, you have diagnostic dysplasia, and you have a clonal abnormality. For CHIP, however, you have only clonalities, but no cytopenias and no diagnostic MDS. IDUS is again a little tricky to actually establish where there are no cytopenias. Dysplasia is also less than 10. So the boundary is not mutation presence versus absent. So we are not looking at a clean sheet, demarcation of a positive or a negative, but it is very much an integrated evidence of cytopenias, morphology, clonality, and at the same time, primary exclusion of mimics. So it shouldn't be the fact that you're wasting in time into looking all of these brother-sister entities all together, whereas the cause is something else. It's in one of the mimics, right? So an integrative evidence is needed. So whenever you are looking out how to sign out a Marrow, where you have this kind of picture for unexplained cytopenias or a query, CCAS, which needs a close follow-up. So always mention about the cellularity, always about the ME ratios and the lineage representation. Your blast percentage typically very well calculated. Your dysplasia wherever is relevant by lineage and extent. Your iron status or your ring sideroblast, the evidence or the extent of fibrosis or infiltrates, your flow findings if done, and cytogenetic and molecular results. Also, along with the evidence, always report the uncertainty, which is actually leading you to probably suspect this could be CCAS. So always state the major mimics which were considered for reaching this kind of diagnosis. Avoid overcalling mild dysplasia. So dysplasia interpretation has to be very typical when we are planning to maybe label a patient as CCAS. You have to correlate with nutritional, drug, infectious data if available, and you use compatible with support or supports with wherever appropriate. And you always recommend a close clinical follow-up when clonality is present, but the criteria are all incomplete. So avoidable errors whenever we are looking at diagnostic traps in cytopenias is first, yes, whenever we're looking at microcytosis picture. So you call it MDS from microcytosis alone. So this is one of the diagnostic traps. Ignoring your platelet clumps, where you are actually over-reporting your platelet counts, where you should actually, whenever you're seeing clumps, you have to give a corrected count. Using your marrow cellularity without age or context, it is a criminal offense to actually give or explain a marrow cellularity without having an age context to it. Overcalling erythroid dysplasia in a B12 or folate deficiency, which is very tempting to actually do it on a bone marrow. Treating any symptomatic or any somatic mutations as proof of MDS upfront. You are missing fibrosis on infiltration because the aspirator is hemodiluted or dry, or interpreting each lineage independently instead of as one hematopoietic system. So individual lineages usually do not lead to a constellation of a diagnosis. So probably all together would usually help. So an integrated cytopenia roadmap is unexplained cytopenias. You look at your CBC and kinetics. You look at the severity, your lineage pattern. You look at the peripheral smear. All of these things all together. You look at the clonality wherever possible or wherever relevant. You look at the clinical exclusions, the very common ones like drug, nutrition, infection, evidence of splenomegaly. A detailed clinical history taking is very important. And when you do not have any answers with either of these, we do a marrow. You look at your cellularity, you look at your blast, your dysplasia, and your fibrosis. What are the advances with unexplained cytopenias, right from morphology to clonality to quantitative risk prediction? So the diagnostic paradigm has shifted. So earlier it was persistent cytopenias or unexplained cytopenias after excluding nutritional, drug, or infectious causes. a marrow morphology is warranted, followed by a karyotype, an MDS or a non-MDS or any other diagnosis. Now the morphology is central, but it is also integrated with your NGS-defined clonality evidence, your mutation types, your VAF values, your cytogenetic architecture, and a longitudinal blood count kinetics to actually establish if this is an acute episode or a chronic one, or we are looking at a persistent phenomenon. And the next is why, because the risk is becoming very quantitative. And it is very important for clinicians to actually be very proactive at the time of diagnosis as to what kind of response are we contemplating at. So, a lot of progression prediction models in CCUS, molecular MDS risk models, digital morphology is also at the forefront for actually giving you predictive models. And AI models are also in place or in research models, minimally invasive peripheral blood genomic approaches. But yes, it is all very contextual and needs a lot of expertise. So, a lovely article from 2025 if anybody wants to go through that. Unexplained cytopenias is now a genomic diagnostic problem. Yes, but the core will always lie with your basic workup of your CBC, your peripheral smear, finding out what compartment problem are we looking at. And as already discussed about the entities of ICUS, CCUS, and MDS. But yes, modern classification, it does increasingly recognize your genetically defined diseases, but it has to be integrated with your morphology, blast, cytogenetics, and moleculars. So key advances, the question is no longer simply it's a mutation present, like if it's present or not, but which mutation, how many mutations at what VAF and with what phenotype, because we need to know if they are actually clinically significant. Do they solve the therapeutic problem or not? So CCUS mutation pattern, it now drives the risk stratification, higher risk, lower risk contexts or clinical sequences. So again, a wonderful article from 2025 which explains about CCUS, where you're looking at spliceosome mutation, TP53 mutations, multiple mutation, large clone size, and cytopenias, which adds a clinical information. So this is already covered. And your molecular risk models, they are entering into routine MDS thinking, the kind of case one that we had discussed. IPSSM, the molecular prognostication model is increasingly used to predict the treatment response and to prognosticate the patient into risk models. And why this matters for cytopenia is a cytopenic patient, it crosses the diagnostic boundary into MDS, can now be stratified with a substantially richer biological information, but the diagnosis and prognosis are increasingly linked to the same genomic dataset. So practical implication for this is no matter how much we're talking about, moleculars and cytogenetics, and also the fact that majority of the centers are still resource poor, we need to have a proactive measure of preserving adequate marrow or peripheral blood materials for integrated molecular genetic testing and diagnosis. So, wonderful workup by WHO 2022 regarding these three typical mutations for unexplained cytopenias. NGS can contribute to classification and not only prognosis. Digital morphology and AI, they are also becoming credible adjuncts when we are talking about cytopenias, where it is being used. So, automated recognition of your patterns or cytopenic patterns or morphological patterns or dysplastic patterns. There's standardization of flow cytometric MDS signatures, multidimensional integration of phenotype in genetics, where looking at the phenotype, we are predicting or having predictive prediction models as to what kind of molecular signatures or what kind of genomic signatures we are going to see. There's reduction of interobserver variability. However, it does not replace yet an expert marrow morphology. It remains the diagnostic reference in many ambiguous or unexplained cytopenias. AI tools, however, they require external validation, harmonized acquisition, and clinically meaningful thresholds before the routine replacement of expert interpretation. So AI tools are not that easy to use, and probably not every pathologist is trained or expert into actually using AI tools into day-to-day models. So a near-term role is augmentation, reproducibility, triage, and pattern recognition. And can we eventually diagnose some cytopenias without a marrow? So yes, there are peripheral blood genomics, increasingly informative for detecting myeloid clonality, also MRD assessments. They're potentially useful for longitudinal surveillance. Digital blood morphology, where you're looking at image analysis, it may extract reproducible cellular features beyond the conventional manual classifications. And current limitations, however, is Marrow remains essential, however, when cellularity, architecture, fibrosis, or blast assessment, dysplasia, or infiltrative disease has to be established. Also, when you have to rule out systemic causes like drug associated or immune process associated. So, probably not a good tool for AI to predict those, which requires a good systemic workup. So, possibility of improvement, fewer unnecessary repeat marrows, but yes, not elimination of a marrow examination entirely. Then cytopenia is becoming a longitudinal diagnosis. So cytopenia at a given time point when the samples are received at the lab are not the norm. Always, it's not a static snapshot. So it has to be an evolving clonal disease and evolving history taking as to if the patient had a previous history of cytopenias. Are we looking at 1 point cytopenia? Are we looking at a chronic cytopenia, persistent cytopenia? Or probably also in improving cytopenia, probably HB was maybe 4, 5, 6, but it does not go beyond a certain number and it is still cytopenia or anemia at this point. So it is a pretty much a longitudinal diagnosis rather than a given time point diagnosis. So a static snapshot it gives you when you're doing your CBC, one Marrow, one NGS panel, but it may not capture an evolving clonal disease or an evolving disease process. Because, like as we saw in the previous slide, if you're looking at a transitioning Marrow where the cellularity is normocellular, so it would be a little difficult to pinpoint on the diagnosis or the cause of cytopenias. Dynamic surveillance, where you're looking at serial counts, you're looking at your clone size, your WAF evaluations, your new mutations, changing morphology or transfusion requirements. And there is a trigger for reassessment where there's worsening cytopenias, new macrocytosis developing, new monocytosis or blasts coming into the picture, or you're looking at an increased clone burden or new clinical features altogether. So the emerging endpoint is not simply like CCUS versus MDS or just cytopenia right now, but it is the probability and trajectory of the progression of the disease process in general. So what should change in our cytopenia workup? So do not stop at morphology when cytopenia remains unexplained. Use NGS to establish and characterize clonality, but interpret the mutation with a clinical context. Report VAPs, mutation number, and high-risk gene patterns, but not simply as NGS positive or negative or mutation seen, not seen. Integrate WHO or ICC genetically defined MDS categories where criteria are met. Use a molecular prognostication systems, and for CCUS, where you have to move towards risk-adapted longitudinal surveillance and expect digital morphology AI, peripheral blood genomics to augment, but not immediately replace your marrow expertise. So morphology, clonal architecture, longitudinal risk. So there's a more precise diagnosis than one single test can provide. So this is one of the cytopenias that is very commonly seen after CAR T cell therapy. So just a brush through. And so we are looking at an immune effector cell-associated hematotoxicity after CAR cell therapy. So cytopenia after CAR is a distinct toxicity syndrome. So it could be early, late, and early is days 0 to 30 after a CAR T infusion, and late is after 30. So the grading emphasizes the depth and the duration of neutropenia rather than a single time point notification. And after day 30, it is a persistent or a recurrent neutropenia, anemia, thrombocytopenia, pancytopenia, which may continue well beyond your lymphodepletion. And why it matters? It could be profound. You're looking at prolonged cytopenias, increased infectious and bleeding risk, which can delay your subsequent therapy. So why does CAR T cell prolong your cytopenias? Because before infusion, probability is the patient had a poor marrow reserve. You have a history of prior therapy or transplant. There is a baseline cytopenia to begin with right from the beginning. The marrow disease burden also affects your cytopenias after CAR T and your pre-existing clonal hematopoiesis. So probably the patient had a clonal component before your CAR T or before any treatment therapy was initiated. So early after your CAR T infusion, your lymphodepleting chemotherapy could be the cause, or systemic inflammation or a cytokine release syndrome could be the cause. Your cytokine-driven suppression of hematopoiesis is a cause, or we're looking at a new infection or a critical illness, which is actually causing the cytopenia. Or it could be a prolonged or late, where there's a persistent inflammatory marrow dysfunction. So the inflammatory process is pretty much playing havoc with your bone marrow microenvironment. There is an immune dysregulation. It is because of infections again, or drug associated, or an entirely possibility of a disease relapse, or we're looking at a secondary myeloid neoplasm, though very rare. So it is multifactorial. It is not simply a delayed chemotherapy recovery response. So recognize the characteristic cytopenic count trajectory. Are we looking at lymphodepletion or at the time due to CRS, or it is at the time of recovery, or it is late in onset? So if you're looking at a quick recovery, expect an early marrow recovery after lymphodepletion, a biphasic course. So there's an initial recovery followed by a second cytopenic dip, which is a recognized post-CAR T pattern, and an entirely aplastic course where there is severe cytopenia without a meaningful count recovery and which requires urgent investigation and support. So CAR hematotox score is the one which was recommended by EHA EBMT consensus recommendation, which predicts your vulnerability before your infusion. So we are being very proactive where we are having a scoring system which is actually going to help you make better decisions. So what the score captures, a pre-infusion risk tool which integrates a hematopoietic reserve or a baseline counts to begin with, and a systemic inflammatory state. So, higher risk patients have a greater likelihood of prolonged neutropenia and infectious complications. How to use it? Risk stratification. It can inform the intensity of CBC monitoring, your infection prophylaxis strategy, consideration of earlier GCSF, or planning for a prolonged marrow suppression. So, it complements but not replaces your clinical judgment. So, persistent cytopenias, the marrow differential is critical for effective clinical decision making. Where if you're looking at a marrow failure, you're going to see hypocellularity, reduced progenitors, maturation suppression, no convincing neoplastic clone, and you interpret in the temporal CAR-T context. Or there is a disease or inflammation etiology where there is a residual or relapsed malignancy, your HLH like hyperinflammation, opportunistic infection, or drug associated suppression, or an entirely different, that is a clonal myeloid disease where you have developed a therapy related MDS or AML. Probably you had a pre-existing chip or a CCUS with clonal evaluation, which unfortunately was not worked on, where you have a new cytogenetic abnormality or you have increasing myeloid clone burden. So persistent or unexplained late cytopenias should not be automatically attributed to the CAR-T process itself. It's a lot of confounding factors that go hand in hand. So hematpathologists work up for this based on morphology, flow, cytogenetics, molecular, or a clinical. So best practice to compare the post-CAR T marrow with the pre-CAR T genomic and morphological baseline wherever is possible. Management, not my area of expertise, but yes, this is what I found in the literature, where you have a supportive management, irradiated blood products, anti-infective prophylaxis, and aggressive infection evaluation, growth factors, early GCSF from day 2. Kindly correct me if I am wrong in this, and use according to patient risk and institutional practice, and refractory. Selected patients, they may require a autologous CD34 stem cell boost, individualized thrombopoietic support, and rarely allogenic HCTs in exceptional refractory marrow failure. So we are almost coming to the end. 7 minutes to go. So what is emerging? Yes, post-CAR T secondary myeloid neoplasms, they are rare, but they're increasingly reported. Some patients, they may harbor a chip or a CCUS or a unexplained cytopenia well before your CAR T, and clonal evaluation has now developed into a therapy-related myeloid neoplasms. And recent studies, they suggest risk is concentrated into biological vulnerable clones. Practical response is all of this, and an emergence interface between cellular therapy and in hematopathology. So take-home message for post-CAR T cytopenia algorithm. Look at the time point where we are looking at cytopenias, the severity, the ANC depth, the duration, how much is the transfusion dependence, the infection or bleeding history, your context, either due to infection, drugs, baseline marrow reserve, your marrow, is it persistent cytopenia, severe or atypical cytopenia, where morphology and flow would be very helpful. Clonality evidence, compare with your pre-CAR T baseline. ACT, support your GCSF, risk-adapted prophylaxis, and a stem cell boost in selected refractory cases. So take-home message, cytopenia is a phenotype, not a diagnosis in itself. Localize the mechanism before naming and classifying the disease. Reticulocytes and smear is a wonderful start point to begin with, and it often determines the direction of the further workup. Multilineage cytopenias with poor marrow response deserves a marrow cause thinking. MDS is an integrated diagnosis. Please do not jump to it for every case with high MCV. So it has to be an integrated approach of morphology, cytogenetics, molecular exclusions. Hypocellular cytopenias demand deliberate separation from aplastic versus hypoplastic MDS. And the best hematology diagnosis is the one that reconciles your blood, marrow, and your clinical context and biology. So these are my references. And thank you very much. And I would love to take if there are any questions.
Thank you, Dr. Neha, for the beautiful talk, lovely presentation, a lot of education.
Thank you, sir.
Questions? One question that PGs often ask, and I can put it to you, is how confident you can differentiate between hematogones and the residual or re-emerging blasts.
On flow cytometry. So,
Flow cytometry morphology.
morphology. So the first thing I would say is always look at what kind of marrow procedure you have done. So was the technique very right in place, or we are looking at an absolutely different picture because probably the marrow, your needle did not hit in the right place, or probably you were not pretty much in the marrow. Based on morphology, yes, it is very, very tricky. But yes, if you're looking at this kind of picture, always confirm it with a flow cytometry. So there's no harm in confirming it with a flow cytometry. Try not to be too adventurous, or try not to be too too risky and trying to establish it just based on morphology. So there are tools which actually help you out. Firstly, make sure the technique is very proper. Secondly, if you have a high index of suspicion, always confirm it over flow.
Thank you. Any questions, please? And one is my personal question. Is it easy to differentiate between copper deficiency causing dysplastic changes versus primary MDS? The copper deficiency is very rare. MDS is very common. In the
Yes.
MDS, occasional case, how do you pick it up?
So I would want to have a context of the age also for this, a context of your biochemistry also for this. And if there's a high index of suspicion, you might as well do a serum copper or a ceruloplasmin level. So there's never a problem with actually confirming if you have a rarer diagnosis in place. And also, if the patient is not fitting into the clinical context or a diagnostic algorithm of MDS, you can surely confirm if you're not looking at a copper deficiency.
Sure. Anybody else? Any question? We have a couple of minutes left.
Good evening, ma'am. Dr. Gopinath here.
Good evening.
Ma'am, just regarding the recent application of flow and diagnostic of MDS. So how do you take it? Like flow cytometry, how is it really to the practice? I mean, can it be really put forward to practice?
Okay, so thank you for the question, Dr. Gopinathan. And I believe I had a similar question last time when I had a webinar. So for MDS, flow cytometry is a little tricky. Firstly, as I said, again, for flow cytometry, you need to be very sure if you're looking at an optimal sample. If you're looking at a hemodiluted aspirate, it becomes very difficult to actually establish the maturation patterns, the defects in the maturation patterns, the actual blast percentage. So if we have this kind of picture, I would always suggest to have the more specific test in place, because firstly, resource poor settings, so for us it becomes very difficult. So we have to a lot of times choose if we can offer the patient either an MGS or a karyotype or a flow upfront. So if your marrow is having this kind of picture, so you have cytopenias, you have a hypercellular marrow, you have enough sample, your patient has got enough money, yes, you can surely do the flow for academic purposes. But as eventually you would need a molecular prognostication model in place, because that would be much more helpful to the clinicians to establish a treatment response, to have a predictive models in place before the treatment, because with just based on the flow it becomes very difficult to actually give that kind of information to a clinician. So if finances are an issue with the patient, I believe instead of having that, maybe it may be a hit, it may be not, probably directly jump to an NGS. And yes, if you do not have, you have that kind of resources, so please complete the picture, look at what kind of flow response you're seeing, what kind of blast percentages you're seeing. But I believe dysplasia becomes very evident on morphology. So for us in our unit, we have hardly done any flows for any of the MDS cases, and fingers crossed, we were able to diagnose majority of them up till date. So we have got a good NGS picture, a good molecular signature, a good karyotype picture for these cases. So honestly speaking, we have not done much flows for MDS, but yes, it could be a good practice to start with, probably maybe some finding if you have, which could help you with the prognostication model. Because no matter how much workup we are doing, I believe the workup should always aim at giving maximum predictive prognostic information to the clinician, because that is what eventually matters the most. How well are we able to treat the patient? How well are we able to have that clinical help to that patient?
Thank you, Dr. Neha. I think we're using all of our time now. So thank you so much for being with us this evening.
Thank you.
Great
Thank you
talk
so
and a
much.
wonderful discussion. Thank you.
Thank you, sir.
Move on to the second webinar this evening, and I'll share my slide to introduce our second guest speaker. So we have Professor Dr. Samir El Hadidi from Dallas, Texas. So he's Associate Professor, Clinical Director of Amyloidosis Program, Section of Hematological Malignancies and Cellular Therapies, Division of Hematology and Oncology, Harold C. Simons Comprehensive Cancer Center at Dallas, Texas. Dr. Samir El Hadidi, MD, MS, is an Associate Professor in the Department of Internal Medicine at UT Southwestern Medical Center. He specializes in hematology and oncology with an emphasis on plasma cell disorders, including myeloma and light chain amyloidosis, cellular therapies, including CAR T therapies, and hematopoietic stem cell transplantation. He earned his medical degree at the University of Jordan School of Medicine. He completed a residency in internal medicine at Hurley Medical Center, Michigan State University. He received advanced training through a hematology and oncology fellowship at Baylor College of Medicine in Houston. He also holds a master's degree in clinical research and statistical analysis from the University of Michigan in Ann Arbor. He is the clinical director of the amyloidosis program at UT Southwestern Dallas, Texas. He also serves as leader of the Fellows Plasma Cell Disorders Clinic. He is nationally recognized as an expert in treating myeloma and utilizing cellular therapies for plasma cell disorders. He has delivered national and international presentations and published over 140 peer-reviewed academic articles related to his areas of expertise. Today, he's going to speak to us on BCMA-directed therapies in early relapsed myeloma, how to choose. I'll stop here and request him to share the screen.
Thank you so much for your kind introduction, and good morning or good evening for you, everyone. It's still the morning here in Texas. Let me just share my screen. Hopefully you're seeing the screen well.
Yes.
So this, thank you. So the talk is about BCMA-directed therapy in early relapsed myeloma and how to choose. So those are my disclosures. And the overview for today's talk will be talking initially about the rationale of BCMA targeting, why it's an important target. I would argue probably the best target we have so far in myeloma. And then we'll talk briefly about studies in late relapse, which establish those as an important agents to use in early relapse. And we'll focus our talk on 3 strategies, including CAR T-cell therapy, bispecific antibodies, as well as antibody-drug conjugates, and how we can choose between those available therapies. And then briefly mention that those are coming to the front line with some early phase studies reading out. So initially, BCMA targeting, a few years ago became really a hot topic, and BCMA is, or CD269 is actually a transmembrane glycoprotein, and it's one of the TNF receptor family membranes. And you could have seen that this is actually mainly expressed on mature B lymphocytes, but also expressed and overexpressed on plasma cells in multiple myeloma. So it makes it a very attractive target to target. And activation of BCMA is important for the survival of plasma cells. And there is 2 important ligands, APRIL and PAF. Both of those actually have a higher affinity for BCMA. And whenever those are activated, this is what the plasma cell and myeloma cell actually depend on for survival. So the idea of targeting BCMA is to kind of suppress the downstream gene expression and ultimately result in multiple myeloma cell death. And there's few ways to target BCMA. There was the first one that we kind of, studied was the antibody drug conjugate. As many of you are well aware, this technology is being used for other solid malignancies, specifically by having an antibody that is linked to some sort of toxic chemical or chemotherapy. And whenever it binds to BCMA, it actually sort of inject this toxin inside the myeloma cell, and ultimately the myeloma cell will die. The problem with antibody drug conjugates are some of the side effects that were associated with it, which we will discuss in details. But then CAR T cell therapy became a thing, and what we're focusing on is autologous CARs. Those are CAR Ts that are actually done outside of a human body, manufactured, and given back to the patient. And what they target is BCMA, and we have two approved products in the United States. We usually actually one of them nowadays more than the other. And the idea is the CAR T cell therapy, as you all aware, been used previously in acute lymphoblastic leukemia as well as lymphoma, and it became an important target in myeloma, specifically for BCMA. Bispecific antibodies are sort of the most recent development when it comes to approved products, and that has to do with using the patient own immune system to get activated for cell death by targeting both BCMA as well as CD3 or T lymphocytes, and that results in ultimately cell death for myeloma cells. So as you can tell, the antibody drug conjugate as well as bispecific antibodies are off-the-shelf products, while CAR T cell therapy is a product that requires manufacturing, so it's not available to a given patient before that. So initially, what got this to actually be important is the fact that there was some patients who were 5 years who got CAR T cell therapy, specifically cell to cell, who did not relapse. And many of those patients actually are 6, 7+ years. And now it's been more than a year ago when this presented a long-term follow-up of CARTITUDE-1 study, and that made it to, as an important aspect of can we cure myeloma. And me spending some time in Arkansas, we believe that myeloma is curable for some subset of patients, even with toxic and or cytotoxic chemotherapy. But the idea of having a relapsed patient, multiple lines of therapy, being off therapy 5 years plus after CAR T, brought this to being in the news, and that actually made us, as a myeloma community, convene earlier this year and try to come up with a definition of cure in myeloma. And this is some sort of working definition, so hopefully we'll get some tweaks in the future. But at least we moved from the idea of uncurable malignancy to curable malignancy, and that's based on the long-term data from CARTITUDE-1 study. And you can see the proposed definition based on the presence of complete response, as well as minimal residual disease negativity, 10 to the -6 for 5 years after stopping therapy. So this way we'll move from continuous therapy to time-limited therapy, and hopefully that will allow us to have this as a target to get patients into the curability portion of myeloma. We also request those patients to get at least 4 out of 5 years advanced imaging, which are negative, to avoid missing some hyposecretory or non-secretory multiple myeloma lesions. And this is the long-term follow-up of CARTITUDE-1. And you can see that the 5-year progression-free survival, as well as the 5-year overall survival, we nowadays tell patients that it's expected that 1 out of 3 patients will be cured, meaning they're off therapy for 5 years plus and still don't have either death or progression of their disease. And that's what actually, is sort of appealing to patients, the idea that you could have cured this with, short duration therapy. The progression-free survival for all comers is around 3.5 years. So not all patients will achieve the cure, but certainly a third of those patients were long-term survivors. And if you look at the later line data, this is a summary table of the products that we have studied over the years. Cell-to-cell, ide-cel, and anito-cel. Anito-cel is not yet approved in the US. It's likely to be approved by the end of the year. But you could see that the overall responses are quite high, close to 100%. And when it comes to the median progression-free survival, the cell-to-cell, by numbers, is much better than the ide-cel. And that's what made us in the US move away from ide-cel and use specifically cell-to-cell, is the higher efficacy. All those agents are associated with certain side effects, including CRS, ICANS, which are prevalent in all CAR Ts, but the good thing about them, they're rarely higher grades and for most part reversible. But we also learned that there are some long-term toxicities like Parkinsonism that's been reported with cilta-cel for anything between up to 6%. And more recently, actually in last ASCO, that's been determined to be 1 to 2% across all the products when it comes to cilta-cel. The problem with cilta-cel that we have given this product to too many patients, and sometimes in academic institutions, we choose a denominator that is based on our experience rather than the whole denominator of all patients who got it. And that will affect some of those numbers that you could see. So that's why we believe actually cilta-cel is likely better than ide-cel, with the fact that those will be never compared against each other. But if you look at data from real world, you can see that the progression-free survival, even if you try to match cohorts with similar patients, appears to be better with cilta-cel. Now, with the fact that probably the side effects with cilta-cel are more, so there is more ICANS, and likely there is slightly more non-relapse mortality of 7% versus 5%. Now, the good news nowadays, we don't really deal much of that because we're using this in a more appropriate way, and we try not to give patients cilta-cel when they're not supposed to get it. Back in the day, that was the only option without the presence of BCMA bispecifics. So as a summary, in the late line nowadays, ide-cel is rarely used in the US because of low efficacy, and those are very expensive products. So we try to give the patient the best shot at it. Cilta-cel is the most commonly used commercial product, and maybe anito-cel may have some promising use, but this will be dependent on the long-term follow-up. So far, there was no early signals of Parkinsonism, but us who treated patients on this product on a clinical study, we're seeing some relapses that could have been happening early. So we certainly need to have long-term follow-up to decide if anito-cel will be, a product that will be more favorable than cilta-cel. And if you look at the bispecifics at a later line, there are 4 bispecifics approved in the United States. The first one you see in the slide is talquetamab, which does not target BCMA, but I kept it there for a reference as an approved agent. But if you look at the teclistamab, elranatamab, and linvoseltamab, all of those are agents approved for later line of therapy. The short sort of a summary for this, at the later line, when you use those products, you really have 2 out of 3 patients responding to them, as well as those patients who achieve CR. They have a duration of response that is not reached, which is really good. And also the median progression-free survival is at least a year plus. So for late-line therapies, those bispecifics are now gaining more attraction to be used because they're off the shelf, as well as they may not be associated with side effects like Parkinsonism that we see with patients with cilta-cel, for example. So if you look into a little more details into those, you could see that the median follow-up is variable between the teclistamab, elranatamab, and linvoseltamab. Certainly, both TIC and ELRA have longer duration of follow-up. And you could see that when you look at the side effects of those, the CRS seems to be less often compared to CAR T-cell therapy, but infections are quite common. And the reason why infections is common is the fact that BCMA is important for actually also normal plasma cells as well as B lymphocytes. So sometimes we encounter infections on those patients, and specifically in the first 3 months of treatment where we need to be super careful. Other cytopenias seems to be less common, and neurotoxicity seems to be less common. If you could see there is roughly, anything between 0.5% up to 2.5%, which is quite good. Hypogammaglobulinemia is quite common with that. And we don't see really taste problems that we see with talquetamab, which is the GPRC5D targeting therapy. So that brought us to the idea that we need to give those to an earlier use. And what started the journey was CAR T-cell therapy. So in CARTITUDE-4 was the phase 3 study that got a cilta-cel approved for early line therapy in the United States. And you could see those patients enrolled after 1 to 3 lines of therapy. The only requirement was lenalidomide refractory disease, and those patients had no previous BCMA sort of therapy. They got bridging therapy with one of 2 triplets, either pomalidomide, bortezomib, dexamethasone, or daratumumab, pomalidomide, dexamethasone. Those were the standard of care regimen for the control arm. And those patients got cilta-cel and then were followed without further therapies compared to the triplet-based therapy. And you could have seen that most of those patients were on the younger age. So a median age was in this 61 years old. Most of them did not really receive daratumumab per se. There's only 23% of those patients who have refractory disease to daratumumab. And when it comes to the refractoriness, those are a little bit, less heavily pretreated than the usual population. And if you look at the progression-free survival as well as overall survival, the red curves on the Kaplan-Meier is the cell-to-cell, and both the standard risk and high risk disease appears to do better than patients who received standard of care. So for the progression-free survival, if you look at the standard risk disease for cell to cell, this has not been reached. Even the lower part of the confidence interval is not reached. So hopefully we'll have some tail of the curve that is better than CARTITUDE-1, which was at roughly 33% of patients. Now, high-risk disease patient did not derive the same benefit. You could have seen that cell-to-cell median progression-free survival for high-risk disease is roughly 3 years, which is much better than standard of care, which is less than a year. But that actually speaks volume that maybe cell-to-cell for high-risk disease is not, sufficient, and we may need to do a little more for those patients. When it comes to overall survival for high-risk disease who receive standard of care, those patients have roughly 3 years of overall survival, but all of the other metrics are not reached with that most recent follow-up. So if you look into, should we use CAR-T earlier? And I think this idea came even with the bispecifics. The earlier you use them, the immune system may be in a better shape to have better outcomes. And you could have seen that if you use them on an earlier line, it seems that you may have better outcomes because of the good immune system and the fact that patients who are less heavily pretreated may be in a good condition. So there are probably some bias there by selecting those patients at an early line. But the idea is if those agents work very well at a later line and they're very effective, maybe moving them to the front line will be better. And we already seen with CARTITUDE-4 that a comparison with a standard of care resulted in better both progression-free survival as well as overall survival. So if you look at a little more details in this high risk and standard risk disease, and you could see that, for the CARTITUDE-4 patients with longer follow-up, now almost 3 years, we still see that the standard risk disease are the ones who did very well, but there are patients who have high risk disease that they are progressing at a later line. You see lots of actually knots on the Kaplan-Meier because the length of follow-up is not sufficient, and you can see the number at risk is becoming lower and lower. So hopefully with longer follow-up, we'll get to have better, understanding of what would be going on. But with cell-to-cell at 2.5 years, it's expected that you have 71% of patients still progression-free and alive for standard risk disease compared to 52%. So it seems that we're approaching roughly some 3 years for CARTITUDE-4 when it comes to high-risk disease. And that may make us think maybe for high-risk disease, doing bispecific combination may be a better strategy. Now, just for reference, KarMMa-3 is the ide-cel study, the phase 3 study that got ide-cel approved in the US. And you could have seen that this used ide-cel versus a menu of options listed in the control arm. And the progression-free survival was roughly a year compared to 4.4 months. But, this is certainly a different population than CARTITUDE-4, because you can see the control arm has only 4.4 months progression-free survival. Those were daratumumab refractory patients for the most part. So, and that's what made this product be approved after 2 or more lines of therapy rather than 1 or more lines of therapy for cell-to-cell. So when it comes to the side effects, there's important things to keep in mind about those agents. So early on, cytokine release syndrome, ICANS, and even, this hyperinflammatory process where patients may go into a hemophagocytosis course of picture could have happened days to weeks after. But later on, you could have seen this delayed neurotoxicities, which makes some of us a little nervous about using those agents because Parkinsonism is being reported as well as cranial nerve palsy, specifically facial nerve palsy. Also, there is more data coming on the colitis. It's been reported as a very rarely side effect to happen. But when it happens, you're talking about colitis that you could have seen with allogeneic transplant, those patients are really as if they have acute graft versus host disease. They have lots of diarrhea. Many of them require TPN to be, surviving, which is quite, aggressive. But this is not happening much, and there is an understanding that this could have been related to some sort of lymphoma of the gut that happens after CAR T. Long term, those patients have been, reported to have second cancers. And we can also say that we don't really know what will happen on the long term, because nowadays the longest we have is only CAR-T1, and we have 5 years plus of that study. And the good news with the longer follow-up, we didn't really have much of acute leukemias happening with more than 5 years. There were some solid malignancies reported, which speaks volume to the idea that we need to monitor those patients long term. Cytopenias and infections are the most common reasons for non-relapse mortality in CAR-T, and it's very important to keep in mind for any patient who get BCMA-based therapies, including CAR-T cell therapy. So, CAR-T is, transformed the way we think about myeloma, but we also need to realize those are very expensive drugs or interventions. They're not available worldwide, and also they're not universally available even in the US. So there are many patient factors that prevent them from getting CAR-T, including comorbidities, the socioeconomic status, as well as the caregiver availability. There's also problems related to the disease. For example, patients who have high-risk disease may not benefit from CAR-T because it's even not a good idea to give them to CAR-T when they have relapsing disease. The way I think about CAR-T is like transplant. If you want to get somebody to transplant, you need to have them to have some sort of response before getting them to CAR-T. And there is logistical barriers. We still struggle here in the US in the fact that many patients may not be able to come to a center where they can get it. And doing CAR-T in the community is a double-edged sword, because you don't want to really do it in areas where they may not be very experienced with dealing with side effects. So those are quite important. Nowadays, the manufacturing is becoming a little better. So I think this is making it a little better for us to expect what to do for patients. Now, bispecifics became, I think, to be the most competitive thing for CAR-T cell therapy. Those are amazing off-the-shelf products. And one of the really good studies that got presented last ASH and published afterwards is MajesTEC-3. So the way I think about MajesTEC-3 is a similar study to CARTITUDE-4, but technically using Tecdera, because those patients were not really refractory to daratumumab. Some of them were exposed, but none of them were refractory. Their early relapses, 1 to 3 lines of therapy, and those patients were randomized 1-to-1 to Tecdera versus daratumumab, pomalidomide, dexamethasone, or daratumumab, bortezomib, dexamethasone. And progression-free survival was the primary endpoint. Now, if you look into the scheduling dose, and many of you are aware, initially teclistamab was approved at 1.5 mg per kg, but in here, the dose is actually 3 mg per kg for the long term. So after actually the first 6 cycles, patients will be coming once a month to get a dose of DARA and a dose of teclistamab. And steroids are only used for the first cycle and not used afterwards. So it's quite good when it comes to less is more when it comes to those medications. This is how the patient split is. You could have seen that those patients were exposed only at 5% to anti-CD38. All of them got immunomodulatory drugs and proteasome inhibitors, and most of those patients were actually refractory to immunomodulatory drug, close to 82 to 85%, and a third of them were both refractory to proteasome inhibitor and immunomodulatory drug. You could have seen that extramedullary disease were present only in 5% of patients, but high-risk cytogenetics were present on a third of patients. And this is how the overall response is. You could see that it's not about the amount or the percentage of overall response. 89% and 75% may be very close to each other. But what you notice is the stringent CR and CR becoming to be way more with patients who got Tecdera. 77.3% of stringent CR, or CR or better of 82%, compared to 32%. And as you all know, whenever you have deeper responses, that reflects into longer progression-free survival for the most part. If you look at MRD negativity, more than half of patients were MRD negative, 10 to the minus 5, with patients with Tecdera compared to only 17% of the control arm. And that resulted in actually one of the long duration of responses that you could have seen. So you can see this tail of the curve being really flat lots of ticks in there because many of those patients are still to be followed longer. But at 3 years, 89% of patients, they still progression-free and alive, compared to a third of patients in the control arm. So that's quite amazing, because what you're talking about there is, the problem of should we keep them on those medications forever? Because they're really doing very well on the long term, which is really good. And that resulted in one of probably the best hazard ratios ever reported so far in myeloma, hazard ratio of 0.17 when it comes to progression-free survival, as you can see in the Kaplan-Meier curve. So, which is really, really good. Now, when it comes to overall survival, though, you could have seen that, patients, 83% of patients are alive and, by the end of the follow-up, compared to 65%. So even in interim analysis, overall survival did favor the use of Tecdera. And that tells us the earlier you do it, the better you get. But initially, if you notice the Kaplan-Meier curve for the first 3 months, there is a cross of the Kaplan-Meier curve. And this is related to the early infections that happened with the use of Tecdera. So this is an area where we need to be very careful. For example, in Majestic 3, before people understand the fact of infections being too much of a problem, patients were not really, monitored and using IVIG. And once they used it, the number of patients who got in trouble become very, very low, only 1 patient compared to most of those complications happening before implementing of the use of IVIG. And this is what's reflected here. You could have seen that patients become more, cytopenic with the use of Tecdera, specifically when it comes to lymphopenia, as well as neutropenia. But you could have seen that neutropenia is also common with the use of triplet. So neutropenia is 78% and 75% grade 3-4 for both of those interventions. When it comes to CRS, most of those CRS are grade 1 or 2. You could have seen that patients could have had problems related to the fever that is also being reported as part of the CRS. But all in all, patients, apart from CRS that could have happened early on, we don't really see much of a problem on the long term with the use of Tecdera. ICANS is also very rare. It's only 1% of patients getting that. But what's important is those, serious adverse events being a little higher there, as well as, deaths related to adverse events, which is quite close, 6 to 7% of patients across both of those arms. But infections are the most important thing. So if you look at the infections details, hypogammaglobulinemia is quite common with the use of Tecdera, almost universal. 85% of patients became hypogammaglobulinemic. But the deaths that happened with Tecdera was not because of progressive disease, but rather because of infection. So if you look initially in the first 6 months, there were 12 deaths that happened because of treatment, some of them related to COVID, but most of those happened for patients who did not get IVIG. So the idea now that we need to be careful about giving those patients IVIG specifically in the first few months, and maybe we need to really think about limiting the duration of treatment for those patients to allow for improvement for the long term. But a few other things also to keep in mind is grade 3-4 infections is not uncommon in also triplet therapy. You could have seen grade 3-4 happening in 43% of patients on triplet therapy. So myeloma is an immune system cancer. So patients get in trouble with infections, certainly, but Tecdera makes those infections more prevalent, and that's important to keep in mind. And that's what made us think, Tecdera is great, but this is only studied for patients who are daratumumab exposed, none of them refractory. What should we do with our patients who got daratumumab or maybe refractory daratumumab? And this is a study that got actually presented in this last ASCO, published afterwards, called Majestic 9, where patients actually got teclistamab single agent compared to one of 2 options, either pomalidomide, Velcade, dexamethasone, or carfilzomib, dexamethasone. And those patients were, for most part, refractory to daratumumab. And I could have seen the split there, that for patients refractory to anti-CD38, it's 85% of patients. So that reflects more heavily pretreated patients. And the idea is using teclistamab early on better than using other available therapies. And you could have seen that the same story repeats itself, that the progression-free survival was better. This is a shorter follow-up duration of a study, only 1.5 years, 70% compared to 27% with a hazard ratio of 0.29, as well as overall survival was favoring teclistamab with improvement of hazard ratio of 0.6. And you can see that this is across the board. If you see this subgroup analysis, all of those, dots are, favoring the use of teclistamab. So even for high-risk disease patients. So it's very important to keep this in mind that you could have used bispecific as either alone or with the use of daratumumab according to the patient's previous use of daratumumab and refractory status. Those patients have long, deeper responses, again, CR or better in 2/3 of patients with teclistamab compared to only 17% of patients achieving CR or better in the control arm. And the median duration of response was not reached with teclistamab. And you could see the lower part of the confidence interval to be at least 2 years plus compared to 1 year in the control arm. So we're really talking about deeper responses, deeper MRD negativity. You could have seen that patients' MRD negativity was higher with the use of teclistamab, even with a short follow-up of 1.5 years. So if you look into a little bit more details, again, the infection is one important thing you need to keep in mind. And this is an important, nice bar graph there about the infections, grade 3 or 4 over time. So the first 6 months, you could have seen more infections happening with teclistamab compared to the control arm. And this kind of fade away with time. And that's why the first 6 months are the most important ones where you get in trouble with those infections. But we'll also need to realize that those patients, even long-term, more than 2 years afterwards, they still have infections. So that made us think in the community of myeloma that we need to move from time unlimited therapy to time limited therapy, because we may need not to keep those patients on those medications forever, but rather give them a time limited therapy. And this is where we're moving with the field now. Now, one caveat to this, we believe that, those patients who have higher grade infections, they usually have low IgG levels and functional IgG levels specifically. And you could have seen that the grade 3 and 4 infections become more with longer therapy, with this probability of infection with the use. So you can always see that this is incremental. And that's what we may need to think about, using this for a shorter duration of time rather for patients doing it for until disease progression. Now, the other thing is, if we give those patients IVIG, the chances of getting into infections will become lower. And you can see that if you use IVIG for treatment or using it for secondary prophylaxis, meaning that somebody already got an infection and then you start it, you may get more problems compared to use it as primary prophylaxis. So many of us nowadays who use Tecdera, they think Tecdera is not a doublet, but rather a triplet because we add IVIG to it. It's an important thing that we usually do with that regimen. Now, just to mention a few things about the antibody drug conjugate, since we moved on CAR-T as well as bispecific. The antibody drug conjugate, the most recent 2 studies are DREAM7 and 8. You could have seen those summarized there. Those are studies that were done at early lines of therapy. Remember, this drug, blinatumomab vedotin, was approved in the United States, but then the approval was withdrawn because of failure of a confirmatory study. But DREAM7 and 8 studies were done in earlier phase, mostly in Europe and outside of the US, that used a blinatumomab vedotin combination regimen with Velcade dexamethasone in DREAM7 and with the pomalidomide dexamethasone in DREAM8. And you could have seen that more than close to 300, 400 patients treated in both of those arms. But here the complete responses is still lower than what we see with bispecific as well as CAR-T. So 1/3 of patients may get CRs. MRD negativity is roughly 1 out of 4 patients. And the median duration of response, though, is quite good. You're talking about 3 years plus. So the median progression-free survival was also good, with roughly 3 years compared to 1 year, for example, in DREAM7. And that resulted in improvement of overall survival for these patients with 79% compared to 67%. So if you look at the side effects, this is what most of us worry about by using this agent. There are problems related to the eye that we could see with it, which is ocular toxicities. And you could see that the ocular toxicities have been at grade 3 and 4 on anything between 24 to 43% of patients. That include blurred vision. 10% of patients stop the therapy because of that. And on top of it, also there is risk of pneumonias and infections. It's not as high as bispecific, but it's still there. And that resulted in some patients dying because of infections with it. The other thing is also noted with the use of blinatumomab mifedotin combination is thrombocytopenias. And that's also happening more often than the control arm. So in the US, we only have one approved combination for the use of blinatumomab mifedotin, which is BVD, based on DREAM7, and only given for patients who got 2 or more lines of therapy. So if you talk about early, like first relapse, the only 2 approved agents we have are cilta-cel and teclistamab daratumumab. And third line or more, you have ide-cel and blinatumomab mifedotin are options that you could have used on that line. Most of us don't use much of blinatumomab mifedotin, given the fact that we have access to other BCMA-based therapies. But if you don't have access to BCMA-based therapies like bispecific and CAR-T, the use of blinatumomab mifedotin is very reasonable because it's also very shown in phase 3 studies to be associated with better outcomes. So it's important to keep that there was no direct comparisons between those strategies. So what we left with is to try to look into them and see what will be best for our patients. And you could have seen this is a summary of the 4 studies that actually studied the use of them at an early line. CARTITUDE-4, KarMMa-3, MajesTEC-3, and DREAM7. And you could have seen that many patients were enrolled in that. But if you look at the overall response rates, they're higher certainly with CAR T-cell therapies as well as bispecifics. When you look at the CR or better, you certainly can see that the bispecifics at 82%, CAR T or cilta-cel at 73%, compared to 39% for ide-cel and 35% for DREAM7 blinatumomab mifedotin. More MRD negativity are noted with bispecific and CAR T-cell therapy, and the progression-free survival appears to numerically better. Now, with the fact that all of those are not comparisons, but those are what we have available now to kind of judge on what to give to our patients. Now, the other thing to keep in mind are side effects profiles. Certainly, there is no CRS problems with blinatumomab mifedotin, but there is keratopathy problems there. There's thrombocytopenia. CRS could have happened with both cilta-cels and bispecifics, and neurotoxicities could have happened with those agents. So those are things to keep in mind when choosing one over the other. But we also need to keep in mind that those are not the same patients. And this is just an idea for you to look into those randomized control studies that DREAM8, CARTITUDE-4, KarMMa-3, MajesTEC-9, Successor-2, which you also use the CELMoD mezigdomide, they included patients who have various degree of lenalidomide refractory disease, anti-CD38 refractory, as well as exposed disease. So really comparing them against each other, you need to take that with a grain of salt because it enrolled different population of patients with different previous therapies that they used. But, we're trying to look at all of those together. This is a summary of the 3 of those things that we could have considered to use at early line. And I'd argue as with MajesTEC-3, you could have seen that patients were heavily refractory when it comes to the lenalidomide refractoriness, but they were not anti-CD38 exposed and certainly not refractory for the most part. But it has the longest follow-up that you have so far out of all of them, and a really hazard ratio that favored the use of Tecdera. So with that being said, in the US, our preference is to use either CAR-T or bispecific, and we rarely look into the antibody drug conjugate because of the efficacy as well as duration of response. So what happens now in myeloma, if something worked by itself, what we do, we try to combine it to other things. And you could have seen those are early phase studies that looked into combination-based therapies. For example, Tecdera lenalidomide, a MajesTEC-2 study, Tecdera and MajesTEC-3 study, Elradera magnetism-5, Lemvodera or isotoximab Lemvo. All of those are early phase studies. And the idea is whenever you use them early on, you're really having overall response rates that are higher for most part, as well as really progression-free survivors, MRD negativities that quite promising. Now, we know that MajesTEC-3, now we have this Tecdera approved in the US. Elwadera, magnetism 5, there was a press release that there was overall, both progression-free survival as well as overall survival benefit of using it. There's no published data for that. It's likely be published or presented in ASH. So those are things to keep an eye on, indicating that the use of BCMA bispecific early on is resulting in really better outcomes than older therapies. So if you look into other things that also being looked at is the side effect profiles, which are important. One of the things that we worry about is if we use those agents upfront for a longer period of time, are we dealing with more infections? Are we dealing with adverse events resulting in death? And those are very important questions. And I think that's what made us move from continuous therapy nowadays to time-limited therapy. For example, just for reference, there will be a program called Triology Study, which looks into trispecifics targeting both BCMA and GPRC5D. And those studies are being done as time-limited therapy from the get-go when it comes to relapsed refractory disease. And speaking even of that, the Monumental 6 study, which press release that came out, only used time-limited therapy with bispecifics. So I think we're moving from time unlimited to time limited, which is really quite promising. So how to choose between those? And we'll use the coming 5 to 7 minutes to discuss that, and hopefully allow for time to discuss and have questions. But the idea is all about approval. So if you don't really have access to those agents, it's hard to talk about them because it's all about what you can give to your patient. But in the US, we have in this NCCN recommendation now, few of those agents being recommended, and you could see for 1 to 3 lines of therapy. Cilta-cel is approved for 2 or more lines of therapy, and Tecdera is approved for 2 or more lines of therapy. Abecma or ide-cel is approved for 3 or more lines of therapy. For patients who got 3 or more previous lines of therapy, you have both Cilta-cel as well as ide-cel approved for those patients. Now, for 4 or more lines of therapy, we have both Elra, teclistamab, and linvoseltamab approved for those later lines. Now, the good news is now we have actually really good outcomes for patients, that many of those patients were really not seeing the 4-line plus because we're doing very well with them with earlier lines, which is very important. But now more than 2 years ago, the IMWG did actually have some recommendation on the sequencing. And that is, you need to take that with a grain of salt because there was no much data at that time compared to what we have now. But the idea is we have studies supporting the use of bispecifics after the failure of BCMA CAR-T, for example. We don't have it the other way around. There was lots of emerging data also that patients may have a mutation of BCMA when they have relapse if they're on bispecific. And the concept of those patients receiving CAR-T cell therapy afterwards becoming not very, favorable because of lower sort of response rates. So those recommendations suggested the use of a CAR-T if you have access to it and trying to avoid both bispecific as well as ADCs, not to mess up with the CAR-T. But you could have argued that with the bispecifics benefits now, that using it will be really the best shot for the patient because sequencing is a sign of failure. We really don't sequence patients unless whatever we're giving to them is failing. And that's why we think about sequencing. So if you give them something that does not fail, then means sequencing is not valid anymore. And this is how I think about it. Whenever I want to choose the first BCMA-directed therapy for a given patient, I think about it in early relapse, certainly. The first thing that comes to mind nowadays for me is this patient CAR-T eligible, as well if it's available for this patient in a short period of time. And if it's not, I may need to be thinking about an alternative strategy. If it's yes, our commercial use of Cilta-cel is the way we go with those agents. And we try to avoid bispecifics as a holding therapy. We can use it as a bridging therapy. That means we don't use it before the apheresis, we do it after the apheresis. But nowadays, if I have a patient who's a little older, for example, 75 or older, or patients with uncontrolled or rapid relapse, or more, non-conforming product, which is something we used to deal with before more often than now, but we used to give the patient CAR-T anyway. Nowadays, I'll be having a second thought about it and think, you know what, I need to give them those bispecific. And if the fact that those patients have any of those problems, I do think in my mind, is this patient will get a CAR T in the near future, yes or no? And if they're not, my preference is to give them a BCMA bispecific, either with daratumumab or alone, according to their use of daratumumab before. And if I want to use CAR T, but I'm using a little bit of time, the strategy of using GPRC5D bispecific for a therapy before CAR T is being, reported on, and it's also working as a good option because of the fact that you use it for a short period of time. Now, this will change when we have either safer CAR T options, maybe that will replace cell-to-cell, but also whenever we get definite duration BCMA bispecific, that may allow us to think from the beginning. Should I give a CAR T, maybe with some unknown risk like Parkinsonism, or maybe a year of bispecific, and then I can get what I want with that year. So this is a moving target according to where we are right now. There's also some strategies to improve the sequencing that we're thinking of. For example, the Redirect 1 study that was published using TIC-TALC did result in improvement in patients' outcomes with extramedullary disease. Nowadays, I mentioned trispecific. We have a drug called rimantamig that we're having lots of studies open across myeloma, even upfront myeloma, using rimantamig, which is very friendly a drug to be dosed once a month from the get-go. We also have CELMoDs, and the mezigdomide data, for example, was just presented and published in this last month. And that is one of the agents that could have been used with carfilzomib for patients to improve our fixed T-cell recovery. We also have the fixed duration bispecific. We have a study that used to stop teclistamab for patients in deep response and see what happens with them. And the early results of that study is very promising. There is allogeneic CAR T cells. We have studies open on that, but we also have in vivo CAR T cells, which use the own human body to do the manufacturing. All of those strategies are improving the way we access those drugs and hopefully will help us to use those strategies better. So the last thing we want to touch base on is using BCMA in newly diagnosed disease. And this is many studies that you could see, summarized there that used cell-to-cell, for example, or bispecific antibodies at upfront. For example, CARTITUDE-5, finished enrollment, this transplant deferred or not intended newly diagnosed myeloma, and those patients got VRD induction and cell-to-cell with no therapies after. And we're really looking to see how those patients will do, because you could have, also consolidate the concept of cure using cell-to-cell if you get that. We also have CARTITUDE-6, which compared transplant, high-dose chemotherapy, and autologous stem cell transplant with cell-to-cell. The downside of this study that after cell-to-cell patients got 2 years of lenalidomide maintenance, both in the control arm as well as in patients who got cell-to-cell. So it's not a time sort of one and done when it comes to CAR T, but there is also maintenance therapy in CARTITUDE-6. But we also have MajesTEC-4, MajesTEC-7, as well as a Chinese study that used actual BCMA CAR T upfront from the get-go. And all of those are things we were looking forward to see and see results of it. MajesTEC-7 completed enrollment already in the US as of yesterday. So we're looking at those results hopefully in the future. One of the things that just got published recently is MajesTEC-5, and this is just to, to make you think about how we are dealing with the upfront studies nowadays in myeloma. This is very small number of patients, but the idea is if you start giving patients teclistamab instead of, for example, Velcade in this area, teclistamab, Dara, Revlimid, dexamethasone, and you do that for 2 years with a high-dose chemotherapy, you could see even after 1 to 2 to 3 cycles of patients, already the patients are in CR MRD negative. You could see MRD negativity of 100% with early strategy. So what we're having now is tools of success. I think what we have to figure out is to make sure that we use them in a way that we really optimize the care of patients and get the best out of it. And that's the last slide I have. And thank you for your attention. I'll stop here.
Thank you so much, Dr. Samir. Beautiful, wonderful, great learning. So our colleagues are here. They may like to ask some question, and those who are audience from all over, if you have to put a question in the chat box. Yes, Amit, you have a question. Yoga. Go ahead, go ahead. Okay, till they get ready. So what will be the exact scope of ADC? Where do you put them? They are
Yeah,
poorest.
it's yeah. Well, here I guess with us having access to both BCMA bispecific and CAR T, I guess it's really hard for ADCs to compete with them. The only probably area that could have been helpful, if there are patients who live in rural areas that may not have access to either bispecific or CAR T, if they have an access for an eye exam, doing by ADC is possible. Now, the good thing also about ADCs now, they're being dosed every 8 to 12 weeks. So you also can argue that you could get a patient only 4 times a year, give them, ADC, and they still do well for the long term. But for most of our practices now, and with the uptake of bispecifics, so most of us are using either bispecifics and CAR T with very low use of ADCs because of that.
Right. And with ADCs, you don't need gamma globulin at all.
No, we don't really do a gamma globulin. So there is some cost-related things there. So I do think, also, for example, I got to learn in the United Kingdom, they don't have access to BCMA bispecific or CAR T early on. They only have access to blinatumomab vedotin, and it's very reasonable to use it. So if you have access problems to the other two, the use of BCMA with blinatumomab vedotin, 2 phase 3 studies showed survival benefit. So it's quite good. But there is no IVIG, lower risk of infection, certainly, with the use of ADCs.
Dr. Yogalakshmi, your question?
So thank you for the wonderful lecture, because we are getting BCMA-based therapies in India also now. So what if we are having, if we have to choose a bispecific BCMA-based therapy, given the all 3 drugs, which will be the best to choose in the first option, and then which to choose in the second and third option, if we are having all the 3 bispecifics available?
I think that the best choose is probably the cheaper, more accessible for you. All of the 3 are similar when it comes to both efficacy and safety. Teclistamab is the one with the oldest follow-up, longest follow-up, so it has more data. It's the only one approved at an earlier line, so I tend to use more of it because of that. We also have data in the combination with daratumumab with teclistamab. The teclistamab and elebanitamab are both subcutaneous. Linvoseltamab is IV, so that's another thing that makes you think about one over the other. We have more data now on time-limited therapy with teclistamab. So out of all of them, my preference usually to go with teclistamab because we do it outpatient, tend to be the cheaper option for us out of the 3 of them. But it all depends on what you have access to. The 3 are, in my opinion, interchangeable. So hopefully with having 3 of them, you could have choose whatever that can be the cheaper for a given institution. But one downside, whenever you use one of them, and if somebody relapses while on the drug, using another one usually doesn't help. So it's similar to the anti-CD38. If you have DARA, patients with refractory, using isatuximab doesn't help. And I think that's also, as of what you know now, but accurate. So if you start with one, then if the patient progress, I don't think you can use the 2 others.
Okay, sir. Thank you, sir.
Satish?
Yeah, thank you, sir. Good evening, sir. Thank you, Dr. Samir, for that excellent talk. I had a couple of questions. One is the using, if we use, because CAR T cells are not commercially available in India, and we have the bispecific antibodies. Suppose we use a BCMA bispecific antibody, whereas elebanitamab or teclistamab, and we use it for a definite duration. Say with DARA, we use it for 1 year or whatever, or 2 years, and then stop it. If the relapse, how later, if the relapse, you think BCMA CAR T cells will help and the BCMA exhaustion goes? And when do you think the CAR T cells can be used safely? Suppose after 5 years they're available when the patient relapses. Do you think at that time the CAR T cells might help, BCMA CAR T cells might help because we have used BCMA specific antibody or not?
Yeah, I think that's a great question. And I think it will help if you have this 5 years or, at least a year plus of no therapy and the patient relapse after that. But the good news is, like, when you stop those therapies, likely most patients will have deep responses that may not relapse for a long term. So, but in case patient relapse after the brief use of bispecific, those patients can receive CAR T cell therapy. Now, what we do here is we check them for BCMA. I mean, there is multiple ways to check for BCMA, stain for BCMA. You could have do that with immunohistochemistry, but now there are more testing to check, do the patient have BCMA when they relapse? So my get-go is whenever they have a relapse, I get a specimen and check for BCMA. And if they have BCMA expression, then I can try by a CAR T cell therapy. If they don't, then I may think about GPRC5D strategy for that given patient. But with the time-limited therapy, I think we'll have an option of using CAR T after bispecific. But the other thing big is like when you use bispecific, the number of patients who are requiring sequencing is becoming lower and lower. So if in Majestic 3, you're having almost close to 90% of patients alive and progression-free 3 years down the line. So the idea is for how long should we keep them on it? Likely we need to stop it at some point. But also if they relapse after that, when do relapse happen if it happens? As you said, if it happens 5 years, then CAR T by BCMA CAR Ts will be, an option, no doubt.
Right. And Dr. Samir, in your clinical practice outside trial, how are you, are you stopping teclistamab in any patients whom you have started, and when are you stopping them?
So I do stop it, and I have a good number of patients where stopped it. We have a study that we have with the University of Pennsylvania that we stopped it, that was presented in last ASH, and those patients did very well. But I usually depends on the high-risk disease. If I have somebody with high-risk myeloma, I try to use it for 2 years and then stop it. For patients with standard risk myeloma, I guess a year should be a good strategy to try to stop it afterwards. I usually use this also based onto MRD negativity and length of CR. I feel more comfortable with stopping it if somebody is MRD negative, if I have access to that testing, as well as they have no evidence of disease. But I also can tell you, for example, there's a patient we treated in the county hospital with relapsed myeloma who got only 1 dose of teclistamab, not even a cycle. Dose 1 of day 1, and now 2 years after, he's still in remission. So we really don't know if we're over-treating patients with BCMA bispecifics with using what we're using now for a long period of time. But my usual way of thinking about it is a year for standard risk, 2 years for high risk, a little longer for high risk disease.
Great. And when do you use prophylactic tocilizumab when you give bispecific antibodies?
I do it when I do it outpatient. So nowadays, remember, most of those were, they say that admit the patient for observation. We try not to do any admissions anymore. So if somebody have high risk, high volume of disease, I usually try to get them approved for tocilizumab, and I give it with after cycle step up dose number 1, before step up dose number 2, to prevent CRS. And so far, we're successful preventing admissions completely with that strategy. And actually, there are studies in the community. If you use TOSI, you get rid of grade 2 CRS completely. So you end up with grade 1 CRS, which is a little fever. And you could have, salvaged this with steroids or something like that. But in general, I use it when I want to do it outpatient, maybe with patients with high volume or, rapid volume, rapid relapses.
Do we see any high risk of infections if you use prophylactic tocilizumab for all patients?
No, not really. But I think what happens with tocilizumab, it shut down the normal response with fever. So I tend to be I'll take any fever seriously if somebody gets a fever in the first 1 to 2 weeks with step-up dosing, because it could have been that tocilizumab is shutting down the fever. If they get a touch of a fever, that may mean something. But in a study, there was no increment in the side effects profile. CRS certainly was better, and there was no disadvantage for efficacy. So those patients still have the same responses as otherwise they will get.
Thank you so much, Dr. Samir. Thank you, sir.
So Tossi, each time you use just 1 dose?
Only 1 dose. And actually, we use in the US 8 milligram dosing. There is a study that was presented, I think, from Mexico that used 4 milligram, and it's as good. So if you want to even do some sort of cost saving, doing 4 milligrams of TOSI should be as good as 8 milligrams. And that saves the patient from coming to the hospital, getting a hospital bed. So there is some downstream, saving that happens with using tocilizumab. And the other thing that you could have also considered is dexamethasone. We can also use the extra dexamethasone or to try to prevent this, and that's also probably a cheaper strategy to prevent CRS.
And when do you use the first dose of IV gamma globulin?
So I try to use it within the first month of starting the treatment. So within the first month, I do it monthly. And even on the studies, we stop the treatment, the bispecific. I usually keep IVIG for 3 extra months after stopping, just to allow them to recover their immune system. But we usually dose them once a month. So ultimately, the patient will come once a month, get, for example, teclistamab, get IVIG, blood testing. So that's the goal. Once a month of sort of combination of both of those strategies.
With talquetamab, how bad are the skin, nail, and the mouth problems?
So they're actually common, very common. Now, if you think about them, the taste happens in 3 out of 4 patients. So there's 1 out of 4 patients who still taste things well, they don't lose weight. But 3 out of 4 patients get dysgeusia. And for most part, they don't taste anything the way they should have. Like all things taste off for them. So many of them lose weight because of that. The skin is not as of a problem. Most of the patients get a little bit of skin dryness or rash that goes away with symptomatic therapy. The nails are most cosmetic in a way, so it's not very dangerous, but patients don't like it. But mostly the dysgeusia is the biggest problem, I guess, for those patients. So there is a study that is now looking at various interventions to prevent dysgeusia. So that to be hopefully read in the future that include Clonabin use, some people use that with some success. Gabapentin use, some people use that with some success. So we want to see in a study what will work for those patients. But I do believe dose modification once a month is the way to go. And trying to space this out, most patients tolerate it better when you dose it less often.
Yoga Lakshmi, another question? No, okay. Anybody else, anything?
Sir, can I ask one question?
Yes, Satish.
Is the risk of infections less with elranatamab compared to teclistamab significantly?
No, I think all of them are the same. The issue is teclistamab was the first thing that we ever used, and we learned from it. We learned that infections is a thing. So whenever they did the elranatamab studies, they started being more proactive, giving IVIG and so on. And with linvoseltamab, they even start to be more proactive. So you could, if you look at the data, as if there is some improvement in infection across them, but it's only, I think, our improved understanding of how to use those drugs. I do think they're all interchangeable when it comes to what will be a best one to use. One caveat to this, elranatamab may be the only one that is associated with peripheral neuropathy that could have been only related to elranatamab with the structural kind of development of it. Because, for example, some people use elranatamab in smoldering myeloma without Velcade, without any previous use of any other agents that cause neuropathy, and some patients got neuropathy. We don't see that with teclistamab and linvoseltamab. So that's maybe something to keep in mind choosing between them. But there is no difference in risk of infection, only better understanding, I guess.
And so can I ask one more question?
Yeah.
Role of bispecific antibodies in amyloidosis, sir, in your experience?
Well, I think that's the future of amyloid. So we're opening a study of comparing one of the bispecifics for a different company called etantamig. It's the IV once a month bispecific compared to Dara-Cyber-D. So there's a phase 3 study planned to be starting. I do believe that bispecifics in amyloid will be the winner because you get hematological response very quickly. And we know that deep heme responses with amyloid is reflected in better organ responses. So, but this is to be proven. There is also, data at relapsed refractory AL amyloid that using BCMA therapies as a whole group, including bispecifics, will result in deep hematological responses. So I do believe this will be a game changer for patients with amyloid, but this is to be determined by phase 3 study. There's also a phase 3 study using a BCMA CAR-T. It's called NixCAR, that there's data presented, I think, 2 ASCOs ago of relapsed refractory amyloid. Now there is an upfront study with upfront CAR-T versus Dara-Cyber-D. So I think Dara-Cyber-D will likely be beaten by one of those BCMA, bispecific or CAR-T, because of how good those products work.
Thank you. Thank you, sir.
Thank you so much, Dr. Yogalakshmi.
Sir, do we have any problems in the laboratory monitoring of the parameters when we are using bispecifics or ADC BCMA based? Like with the daratumab being the IgG kappa, we have problems in monitoring the during the subsequent. So, is there
So
any problem with it?
Yeah, you could have actually identified those bispecifics through the serum electrophoresis immunofixation. Not as much of a problem like daratumumab, but the way to tell between them, most of those patients who respond to bispecific and CAR-T, they start having unmeasurable free light chains. So you cannot really see any, measurable free light chains. But usually the recirculation half-life of the myeloma protein take longer. So many of those patients, if you do Marrow on them, they're MRD negative. The free light chains are non-measurable, but they still have some myeloma protein just because of the recirculation. So they may achieve the stringent CR a little later just because it takes time for the body to clear the myeloma protein. But it's been reported that you could have catch some protein by using TEC, ELRA, linvoseltamab, all those three agents.
Okay, thank you, sir.
I think that's the last question. So thank you so much, Dr. Samir. You spared your lot of time, and I think we learned a lot. Extremely grateful to you. Thank you.
Thank you so much. Take care.
Everybody have a wonderful day ahead, and good night to everybody from India. Bye.